Hello, and thank you for joining us today to discuss how you can increase the vaccination rate in your patients for the HPV vaccine. My name is Gina Lewis, and I'm the AAP California Chapter 1 President, and I'm also a primary care pediatrician at UCSF Benioff Children's Hospital, Oakland. Our chapter, along with National AAP, have partnered in order to help pediatricians step up their game when talking about HPV vaccination in our clinical practices. As pediatricians, we've all seen the devastating effect that public media has had on our patients' view of vaccines in general. And when it comes to HPV, that topic becomes more difficult because it challenges parents and pediatricians to talk about children's sexuality. Because of the 2010 California law, AB 354, which stipulates that children going to the 7th grade must receive the Tdap vaccine, pediatricians have a unique window of opportunity to vaccinate against other vaccine-preventable diseases like meningococcemia and human papillomavirus. And while around the state, the vaccination rates for Tdap vaccine have continued to increase, the rate for HPV vaccination remains astonishingly low. Today we're excited to share some easy and efficient ways that you can engage with parents and families around vaccinating children against HPV. And after participating in this discussion, you will be eligible to participate in a free Maintenance of Certification Part 4 brought to you by your local chapter and National AAP on how to increase HPV vaccination rates in your clinical practice. So without further ado, I'd like to introduce my colleagues and friends who are going to help explain a little of the background about HPV and also some techniques of engaging families in receiving the vaccine. And to my left is my friend and colleague, Dr. Chuck Whipplesman. He was the immediate past president of our chapter. He is chief of adolescent medicine at Kaiser Permanente San Francisco Teen Medicine, and he is also a clinical professor at UCSF School of Medicine. He's also the author of several books on teenage health, including the Teenage Body book. He's going to be giving us the historic and scientific backdrop of HPV. And to my right, my dear friend, Dr. Katrina Saba, who is in primary care practice, pediatrics at Kaiser Permanente in Oakland. She's always been an advocate for vaccination, and she's recently embarked on a multi-site study on how to engage parents effectively to vaccinate their children, especially the vaccine hesitant and vaccine refusing parents. So I'm so excited to have you both here today, and thank you so much. And I'm going to turn it over to Chuck to tell us a little bit about where we've been and where we're going with HPV.
So let's talk a little bit about the disease and the vaccine. And I think what's most noteworthy is this is really the second vaccine that we've had to prevent cancer. The first one being the hepatitis B vaccine that came out certainly in the 1980s and we've all used and did not seem to have all of the hullabaloo that the HPV vaccine has had. However, if we look at the disease caused by the human papillomavirus, we know that each year approximately 15,000 cases of HPV in women and 7,000 cases in men are caused by the HPV virus type 16 and 18. And then when you look at the males, approximately 5,400 cases of HPV cause cancer of the oropharynx or the throat, and there are also an additional case of over 1,400 cases of HPV cause cancer of the anus and 400 cases of cancer of the penis. So this is something that people die from, and so now that we have a vaccine that we can actually use to prevent this.
And let me ask you a question, Chuck,
Yes.
because a lot of parents are worried that the vaccine is preventing warts, and actually, in my understanding, the vaccine doesn't prevent warts, it prevents the virus that is related that causes
two
cancer.
specific types. So we talk about 16 and 18 being associated with cancer. We also know that the HPV type 6 and 11 are associated with warts and causing warts. But I think, in our discussion, hopefully we will not go there. I think we really need to market this as a vaccine that prevents cancer. And I think parents accept that much more readily than trying to market as an STI or STD vaccine. Now comes our parent, the American Academy of Pediatrics. I mean, they are our leader, and they really have come out with recommendations. And I'm also going to talk about a report that was published in Pediatrics in March of 2012, where the Committee on Infectious Disease came out with a policy statement about the HPV vaccine. And what was so important was that here they were able to step up the plate and give us some guidance. And so the recommendation from the American Academy of Pediatrics was that all children 11 and 12 should receive this vaccine and it be part of the adolescent immunization platform. And the platform includes the less controversial vaccines such as the Tdap and also the meningococcal vaccine. So we have a guidance from the American Academy of Pediatrics to put this as part of a trio of vaccines. And also now, we also know that the vaccine, there are two vaccines for the HPV vaccine. One is a quadrivalent and one is a bivalent. The quadrivalent includes 6 and 11, 16 and 18 viruses. And this is the one that we are using because the quadrivalent has the advantage that it also works for males as opposed as to the bivalent. So this is the one that we'll be talking about. This is what people are using. I think it's important to know that this was a very sexist vaccine back in 2006. It was only women. I'm like, well, why only women? And why do we do chlamydia screening only in women? But that's the way it was. Even though in Australia, they were giving it to boys and girls. So what about the boys? And interestingly enough, even though in 2006 it was recommended for girls, the 11 to 12 being the target age, completion by age 13, there was also what was called a provisional recommendation to give it to the boys. The big problem with that was that we couldn't get reimbursement because there was really not a strong recommendation from the CDC.
It was so unfortunate because, you know, both boys and girls suffer this cancer, different types of cancer, but from the same virus. So really unfortunate that there was that lag and public opinion swayed because of that lag.
Yes, and also, I mean, it was, when you think about it, was not the girls giving HPV to the other girls, but they were getting it from the guys. And again, so why would you only immunize the girls and not the guys? So I think we had to do some around the world thinking to really make this happen. And so when we look at the rates, again, in 2011, this is when it was finally changed and there was a recommendation to give it to boys also. And again, we as pediatricians, then when we would sit down with parents, we would say, we have a vaccine to prevent cancer in boys and girls. Then we looked at, so we've got the vaccine, we've got the recommendations, we've got everything we need from the Academy of Pediatrics, from the CDC to give this vaccine, and yet if we look at the rates of the vaccine, it's very discouraging. If we look at the numbers for 2011 and 2012, only about 34% for 2012, 33% for 2011 of girls have really received 3 doses of vaccine by age 13. And then the HEDIS requirement, that's one that we all have to follow, telling us, you know, it's Health Employer Data Information System, saying you have to hit all 13-year-old girls in your practice have to have 3 doses by the age of 13. And how can we do this when we only have a third getting this? And if you look in more detail into actually what's happening with the vaccine, you know, what are some of the barriers? And I know that's what we're going to be talking about a lot in the discussion today, but some of the barriers really have to do with ethnicity. And I think when we look at the literature and we see that the vaccine is consented by parents much more among Latino parents and African American parents than Caucasian. And so these are barriers that we need to work with. And also I think a lot of the data then as we look at, you know, why the rate is so low and why is it related to ethnicity, the role of the pediatrician. Because most of the literature shows that if the pediatrician recommended the HPV vaccine for the adolescent male or female, it made an incredible difference. And I know over the years, talking with colleagues of mine, other pediatricians, not people so much in adolescent medicine, just saying, well, I wait until age 16 or 17 to have this discussion, despite what the recommendation is. So I think we have a lot of work to do, but that's kind of really the history and the challenge, but we've come a long way and hopefully we'll do much better.
Thank you so much. Very interesting. And I know Katrina has some insight, both professionally and also just her talking with patients and parents. So give us some information about how you engage your families
Okay.
when you talk about this.
Well, I mean, I think we first need to think about why the rates are so low. What's happening to make them so low? And first of all, I don't think this is due to staunch vaccine refusal like we see in the younger age.
No, we have to separate it out because it's not the parents who are refusing the MMR of the infant
Exactly.
or toddler. These are the people who are refusing the HPV vaccine and the flu vaccine.
Yeah, and sometimes the flu or sometimes
Yeah.
just the HPV, but other than that, they're completely vaccinated. So, but I think some of the main reasons, first of all, like you brought up, I think a lot of times one of the reasons why our rates are so low is because doctors are reluctant to discuss the vaccine, especially with patients that they don't know very well. And so frankly, I think one of the reasons why our rates are so low is just that the vaccine isn't being offered. And so when we see someone new in our practice they're new to us, we see that they've had their Tdap vaccine and they've had their meningococcal vaccine, but they haven't had the HPV vaccine, we can't assume that the HPV vaccine was refused in the past. We need to assume that it hasn't been offered, or else we're not going to get anywhere with this. Now that being said, the parents also may be hesitant. I mean, they may have heard misinformation in the media, like you said. They may also be uncomfortable about discussing sexually transmitted infections. And it may just be that they just don't know that they're supposed to get the vaccine for their child now. So with all that background, I think there are a few techniques that we can use to try to make this discussion more comfortable and more fruitful. And the first is when the patient and the parent are in the room with us, we need to set the tone. Okay, we need it to be a very calm, comfortable, friendly environment, because when parents feel at ease with us, they're more likely to agree with our recommendations. Secondly, how we open the discussion about vaccines can make a big difference in the chance that the parent's going to agree to what we say. So there was a study in pediatrics just this past fall, 2013, that showed that if pediatricians use a questioning approach to discussing vaccines, parents are much more likely to refuse than if the pediatricians use more of a directive approach. So if we ask, do you want to get the HPV vaccine today? They are much more likely to refuse than if we say something more like, I noticed that your child is behind on her 11-year-old shots. Let's work on getting her caught up today. And then the actual words that we use to discuss the vaccine can make a big difference. So we can cite all the epidemiological studies we want to about the efficacy of the HPV vaccine, but that's a lot less effective than talking about protecting one's own child. And using that word protection is a really powerful word. So we want to try to use that over and over again. So as an example, okay, so if I'm talking to a girl and her parent, I might say something like, looking at your child's vaccine records, I noticed that she's not protected against the virus that causes cervical cancer, so she needs the HPV vaccine. Or in boys, I might say something like, I noticed he's missing his HPV vaccine. This is the vaccine that we give at this age to prevent cancers as adults, and that would be throat cancers and genital cancers in boys and cervical cancer in girls. Now, or cervical cancer in women, rather. And so at that point, parents certainly may have questions. They might ask, why so young? Or why do we need to give this if our kid's not sexually active yet? And I'm sure you've heard these questions all the time.
No, and we have to answer that. And
Yeah.
we have to answer
Yeah.
why so young? Why would we have to give it at age 11 and 12? And we need to have the answers.
Right. So I think right now what we need to do is appeal to the parent's identity. And we need to appeal to their identity as good parents who've always done everything that they can to protect their children. And we can tell them, like with any vaccine, we want to give the protection from the vaccine long before the child is exposed to the disease, or in this case, way before the child is even thinking about having sex. The other thing we can do with this identity strategy is to try to forge a common identity with the parents. So we can talk about how our own child, or our niece, or our nephew perhaps, was vaccinated with the HPV vaccine and how we felt relieved that they were better protected against cancer. Or we can just find some commonality and show that we, like the parent, have their child's best interests at heart. So to summarize, we're going to do 4 things, okay? We want to have a warm and friendly visit where the parents feel comfortable with us and not confronted by us. We want to have a directive, not a questioning approach, as we open the discussion about vaccines. And we want to use advantageous terms like protection and preventing cancer. We do not need to get into warts. We don't even need to talk about STDs if it's not a natural part of the discussion. And then we're going to try to appeal to their identity as good parents who want to protect their kids and forge a common identity to show that we too have their child's best interest at heart.
That's so great. I want to just tell you about an example of how this pediatrics article affect my teaching with the residents, because I thought it was so powerful. So it really has affected my practice, and I think a lot of us were trained to be collaborative with parents. And when it comes to the vaccines, it just is not as an effective approach. And I've been sharing this article with pediatric residents, and one of them came up to me last week and said, I'm so excited. This family that's never vaccinated against the flu, I told them that the child was due for the flu vaccine and we were going to give it. And they said yes. And they got both doses of the flu vaccine. This is a family that I never thought would do it, and I just changed my approach and it worked. And now she's the biggest passionate spreader of this article and this approach around her residency program. So I really do think that small changes in our pediatric practice can go a long way.
Yeah, and I've seen this work with parents that I have, and especially for HPV vaccine specifically, parents I've never met before, they've refused the vaccine before, and I just use this kind of language and this kind of tone. They never met before, and they go along with it. So,
and one thing that's unique about this vaccine, since we are in California, Chapter 1, is that the law was changed 2 years ago that allows an adolescent, it's not just confident, allows an adolescent to consent to the diagnosis and treatment of a sexually transmitted infection, but also prevention. So many of us may be in the situation where we can actually offer the HPV vaccine to an adolescent, male or female, between 12 and 17, and they can consent. So again, it's also, we can market this to the adolescents, and it's another opportunity, which I think really opens the door for many of us.
I'm so glad you talked
we're
about
very
that.
proud of that.
Yeah, I'll do that. Yeah. So sometimes if I'm seeing the teen alone as part of a physical or whatever, and the parents outside the room, I'll say, you are due for this vaccine. I'm going to go get your parents so we can talk about it. But I will tell the teen that just so you know, this is the law. You are allowed to consent to this vaccine without your parents' permission, so that they know just in case an issue comes up later.
And it also opens the doors to adolescents who are seen in other settings, such as a Planned Parenthood, where they actually are maybe getting a confidential service, that they could actually receive this vaccine at Planned Parenthood or through the health department without parental consent. So again, it's another opportunity we have.
Good point. Well, I know that we want to take a few minutes to try some role playing to introduce a couple of scenarios so that our audience can see what it might be like with some of the common things that parents bring up, and how to best engage the parent around the vaccine. So should we try and do
So let's do some scenarios, okay?
So I'm going to be the parent.
And I'm the doctor.
Katrina's going to be Dr. Saba.
And I will introduce the scenario. So we will do the setup. So
Okay.
are you both ready?
Yeah, we have a pretend invisible child.
This is our child right here,
Very good.
who will change names.
So our first scenario will be a mom bringing in her 11-year-old daughter who has a finger injury. And so Dr. Saba is seeing Ms. Lewis and talking about the finger, but then it's an opportunity to talk about the HPV vaccine. So go ahead, Dr.
I'm just
Saba.
going to clarify this. She's a 13-year-old.
Oh, I'm sorry, 13. That's
Yes.
13.
Okay.
Okay.
Well, Abby, it looks like it's just a mild finger sprain. Nothing to worry about, nothing serious. I can get you a little splint for it, but it shouldn't keep you off the soccer field. And what a great coincidence that you and my daughter are on the same team. I'll look forward to seeing you at the next game.
Thank you, Dr. Saba.
You're welcome. Listen, while you're here, I was just looking at Abby's vaccination records, and I see she's had her Tdap and her meningococcal vaccines, but she's not protected against the virus that causes cervical cancer. And there's a vaccine for that. That's called the HPV vaccine, and we can get that for her today.
Oh, she's due for that right now, or?
Yeah, we usually actually give it for 11-year-olds, but we can get her caught up today.
Oh, so that means that Abby's brother, actually, he's 11, so he would be due for it as well?
Right, so we give it at age 11 to girls to prevent cervical cancer as women, and then we give it to boys this age to prevent throat cancers and genital cancers as men.
Oh, okay.
So
Okay.
yeah, so he can get it with his other 11-year-old vaccines,
okay.
like his Tdap and his meningococcal vaccines.
Perfect. Okay, well, Abby, I know that you weren't expecting to get the vaccine today, but I think since we're here, Dr. Saba fixed your finger, I think we should take advantage of the time and just do the vaccine.
Great.
Thank you so much.
Yeah, I know you'll feel relieved that she's better protected against cancer.
Yes, thank you.
Really nice meeting both
You
of you
too.
today.
Thanks.
You made it very easy. Didn't have to twist her arm very much. We should do one a little more challenging.
Yeah.
Another.
We will, but I just want to make the point, it can be that easy. And I think this is the case where the doctor didn't make that assumption that the parent had refused it before. The doctor made the assumption that the parent wasn't offered it before. And here's a mom who just didn't know it was supposed to be given. And I think if we assume that they're a refuser and we never bring it up, the kid's never going to get protected. So, yeah, so it can be really easy. And I have this scenario every day in my practice, and it works.
And what's good about this scenario is this is not the regular physician. This is somebody who the mom with Abby just happened to see someone in urgent care for a finger, and all of a sudden the 13-year-old, the physician had the time, which we always cherish, the time to actually discuss more than the finger.
Take advantage of your opportunities to vaccinate.
That's right.
Exactly.
Yeah.
That's right. All right.
Okay.
So are we ready?
Yeah.
Go on to a little more difficult one.
Okay.
So this time we will do an 11-year-old.
Yep.
And in this particular situation, we have a mom bringing in her 11-year-old daughter for the Tdap, which doesn't seem to be a problem. But again, the physician needs to talk to the mom about vaccines other than the Tdap. So go ahead, Katrina.
Hi, Ms. Lewis. Hi, Nayeli. It's so great to see you again. So you're here for your 7th grade physical. I can't believe you're in 7th grade already, Nayeli.
I know. And she needs her Tdap vaccine to get into school next year.
No problem. So I'll order up the vaccines that she needs today, and the nurse can get them ready while we're talking.
That's perfect, because we have an appointment in like 20 minutes.
Okay,
so
no problem.
Okay. Thanks.
So in addition to protecting Nayeli against tetanus and whooping cough with the Tdap vaccine, it's also time to protect her against meningococcemia and cervical cancer with the meningococcal and HPV vaccines.
HPV vaccine, I've heard about that, but she's not sexually active. She's a virgin. And isn't that the one that helps prevent venereal warts and STD? I don't think she needs that vaccine today.
These are great questions, Ms. Lewis. The reason why we give the HPV vaccine is to prevent cervical cancer. And a lot of conscientious parents like yourself wonder, why do I need to be protecting against cervical cancer in my 11-year-old? Well, the reason why we give any vaccine is to protect long before someone is exposed to a disease. So if I were to give Nayeli her measles vaccine after she were exposed to measles, it wouldn't help her. The same thing is true with the HPV vaccine. It sounds like you've done your research, so you know it is a sexually transmitted disease. And so the reason why we give it now, when kids are 11 years old, is that we can protect them long before they're even thinking about having such relations. Unfortunately, once people do become sexually active, chances are that at least 50% will be infected with the HPV vaccine. So by giving it now, we can protect her long before we need to worry.
But do teenagers get cervical cancer?
No, they don't. Yeah, we know that by giving the vaccine at age 11, there's a higher protective antibody response than if we give it to older teenagers. Basically that means it works better when we give it at this age. So that's another reason why we do it now.
Okay.
I know this is hard.
It is hard. I makes sense the way you're describing it, and I certainly don't want her to have to worry about this when she's an adult. So
yeah, I know where you're coming from. So my daughter's just a year older than Nayeli, and she got her HPV vaccines last year. So I know where you're coming from, but I will say I felt so relieved to know that after she got them, that she was better protected against cancer. When you and I go to get our pap smears, and other women our age get our pap smears, we have to worry that the results are going to show that we have cancer. And I'm just glad that my daughter doesn't have to worry so much about that. And I want to see Nayeli get that same protection.
Thank you, Dr. Salva. The way that you describe it, that makes a lot of sense to me, and I think we could go ahead and do it. Especially if we can do it, within 20 minutes.
No problem.
Okay, thank you so much.
Great, you did very well. Do you see any challenges there? Katrina, do you think that there was any situation where maybe you weren't going to be able to convince Ms. Lewis?
I think we have to just sort of just use these points. We really were talking about protection and why we want to protect now. And I will say that after I wrote this script and sent it to you that day, I had a mom in the clinic it was a 15-year-old who was new to my practice, who had refused that vaccine in the past. And I pretty much word for word said what I had said on the script to her when she took it. So but it was all about her, and her questions were just what Gina's were.
Yeah.
I don't think, and she was like, well, my daughter, I don't think she needs it yet because. And she would look at me like that, and so I knew what she was getting at. My daughter is a virgin, et cetera. And so I did bring up the idea. It does sound like this is a sexually transmitted disease. So we don't need to bring that up first and foremost. But clearly, if that's in the parent's mind and that's the elephant in the room, then we can talk about it and explain why we need the protection long before someone's even thinking about getting into sexual activity.
And I mean, you are probably going to bring up the family that's going to refuse vaccine no matter what.
Yes. And
we've all been in that situation. And, I think that it's our job as pediatricians to say, ultimately, this is your choice to protect your child against this vaccine-preventable illness. It is my job as a pediatrician to protect your child and give and offer this vaccine and give this vaccine. So if you don't feel comfortable doing it today, the next time you come back and the time after that and the time after that, I'm going to offer it to you because it's my job to protect your child. And I would feel terrible if your child had a disease or died from a disease that I could have prevented. So I think that really is the onus of the pediatrician to say those words when we have a vaccine-refusing family.
And I think now, in 2006, parents would say, well, how long has this vaccine been out? Oh, just a few months. But here we are, 8 years later, and have you had situations where the parents have said, this is a new vaccine? Because when you look at the data for not anymore, because even the meningococcal vaccine, the success rate there is way high. It's like 68%. The Tdap is 86%, and here we are still with a third. So it can't be that it's a new vaccine. Then I don't think that's really a valid concern. Do you?
I've heard it once. It was a mom who's a scientist, and she, she vaccinated her kid against everything, and so she always had that argument, and then finally her team knew that she could get it on her own confidentially, so she did.
So that's very good.
Yeah.
And I really hope that our colleagues will look at the HPV vaccine just like they look at the meningococcal and the Tdap vaccine or any other vaccine that we offer. There's really no difference. This is a vaccine that prevents an epidemiologically significant vaccine-preventable illness, and that therefore we should be giving the vaccine. It's no different than vaccinating against any other disease. So I feel it's very important that we all start to believe that ourselves so that we can then offer it without hesitation to our patients and families. And maybe this would be a good time for us to open the questions up to our audience.
I use a lot of the techniques that you're talking about today, and I have definitely moved more towards introducing the subject as a cancer prevention vaccine and tagging along the term HPV for later. But I do have a fairly sizable subset of patients who have very strong cultural and religious beliefs that are reinforced by their community that their children will never need any vaccines against any sexually transmitted disease. And although I don't bring up that it's a sexually transmitted disease, that's the first response that I get. And that because it is, and because their children are a part of this community, their children do not need it and will not need it. And that is, I think, my biggest challenge with this vaccine. Where do I go with that?
I think sometimes I talk about that, we do give it, like we said in the scenarios, we do give it early because it works better when we give it early. And then, frankly, that the vaccine isn't even offered after the age of 26. So this is a vaccine to prevent cancers in adult women, but it's only offered during these age intervals. We can only, we might get so far with that, but I've seen it work a bit with that. Just talking about, even married women can get cervical cancer. You could put it that way too, but that it's only offered up until the age of 26.
And what about the idea that HPV now, they scientifically have found, is potentially on the surfaces of our skin.
Yes, and that's such a good point.
Not just in our genitals.
Yes, exactly.
Right, so.
And there's a wonderful gynecologist from actually the North Valley, Walter Kinney, who makes this point so well that HPV is everywhere and it's not necessarily related to sex. And so just because the fact that your son or daughter is entering adolescence and adulthood, the HPV virus is around so much that we're actually protecting them from a virus that's around, not definitely linked always to sexual activity.
So have these studies shown that this vaccine will convey lifelong immunity against HPV, or will our kids decades later require a booster? For example, like how do we know as adults, like we needed another pertussis?
Yeah, there's a very good question. Actually, the latest literature, when they look at the prevalence of HPV, was reduced among adolescent females by 56% after just a few years. And in Australia, they actually 78% reduction in the prevalence of HPV. But your question is very good because we don't know. I think some of the more current evidence and research now is actually showing that maybe you don't even need a third vaccine, that this may well be a vaccine of a series of two. So again, it's just as with Tdap, maybe in years to come, there may be a booster. So we're not out far enough to know that.
But at the same time, even though we're giving this vaccine that's highly effective against cervical cancer, there are not concurrent recommendations to stop doing pap smears. So I think, with time, we're going to see over, does this generation, as they get to be our age, as they get their pap smears, maybe they're going to find they're just not needed as much anymore. So I think time will tell.
But hopefully this is the kind of scenario, just like with Haemophilus influenza, where the prevalence goes down significantly,
So significant, yes.
so that the disease rate will decrease almost to nothing, that seeing cervical cancer will be as rare as seeing meningococcal disease from meningitis from H flu.
And they're actually seeing that, I excuse myself that I don't remember what country this was in, but in one of the African countries, they were doing prevalence studies of cervical cancer after the HPV vaccine, and they're actually seeing a lot of herd immunity. So they're actually seeing less cervical cancer in women who, in a population that did not get vaccinated because much of the population did.
Yeah, but it's so encouraging in Australia because they started giving the vaccine so much sooner than we did in the United States, and to see a 77% decrease in the prevalence is amazing. So we're off to a great start.
My question's a little bit different. When they finally recommended that we give the HPV to boys, I was very happy to hear that, and I have been asked, and I've asked the question, why didn't we offer it to both the boys and the girls at the very beginning?
It's a very good question, and really it parallels the whole sort of evidence-based thinking and approach as with chlamydia screening, where the HEDIS requirement for chlamydia screening is females only, as if they're the only ones. And that the whole basis for chlamydia screening of females only has to do with chlamydia causing pelvic inflammatory disease and infertility. They're looking at morbidity and they're looking at mortality. And so that same thinking and evidence-based approach had to do with the HPV and cervical cancer. Cervical cancer was the cancer of women. Now, if we go back to 2006, and if we had this data around throat cancer and oropharyngeal cancer, maybe that would have been a difference. There would have been evidence that, wow, if 6,000 men are dying of throat cancer related to HPV, we should do the boys also. So it's a good question.
I think the flip side of that, though, is because there are a lot more cervical cancers than these other cancers, that's why they went for girls when they were looking at cost-benefit analysis. But when it came down to cost-benefit, there weren't enough girls getting vaccinated. So to make it beneficial, they had to offer it to boys. And that's why it came down to the cost benefit, is because girls weren't getting vaccinated, they actually had to start vaccinating more boys so that we could protect our girls.
Thank you for joining us in this discussion of how to increase the HPV vaccination rate in your patient population. We now invite you to participate in a free Part 4 Maintenance of Certification project made possible by National AAP and EQUIP. We hope using some of the techniques discussed today will improve the rate of HPV vaccination in your practice. Thank you.